right now we're going to be talking about sexual pain, and I'm honored to have in the studio with me once again. She was here last week talking about sexual desire, but Dr. Lori Brotto has a PhD in clinical psychology from the University of British Columbia, UBC, and a fellowship in reproductive and sexual medicine from the University of Washington. She's an associate professor in the UBC Department of Obstetrics and Gynecology, head of the Division of Gynecological Specialties, and has a small private practice as well. She's a registered psychologist in Vancouver, director of the UBC Sexual Health Laboratory, where a lot of the sexual health research focuses on developing and testing psychological and psychoeducational interventions for women with sexual difficulties and genital pain. We're going to be talking about vulvodynia tonight. Welcome to the studio, Dr. Lori Brotto.
Thanks for having me, Maureen.
Oh, it's great to have you here. And also, Dr. Carolin Klein is a registered psychologist and the director of the Multidisciplinary Vulvodynia program at Vancouver Hospital. She received her PhD in clinical psychology from UBC and subsequently completed clinical and research fellowships with the UBC Sexual Health Laboratory. Did you know that we had a sexual health laboratory here in Vancouver? A lot of people don't realize that. She's also done some dialectical behavior works at the Dialectical Behavior Therapy Center in Vancouver and is a specialist in that area. So Dr. Klein and Dr. Brotto both work with vulvodynia, which is a type of sexual pain. So can you explain exactly what vulvodynia is? It's a big word for a lot of people. A lot of people don't even know what the vulva is.
Sure. I think it's important to recognize, first of all, Maureen, that most women at some point in their life will have some pain or discomfort with vaginal penetration, whether it's through intercourse or trying to use a tampon for the first time. But what we're talking about here with vulvodynia is really a chronic condition. So this is the woman who says that there's ongoing pain at the entrance of the vagina, at the vestibule, which is the area that includes not only the vagina itself, but the inner labia as well. And vulvodynia is a bit of an umbrella term. It refers to pain in general in the genital area. But within that umbrella term, there's really two specific conditions that we see a lot of. And the first condition is something called provoked vestibulodynia. So that's the woman who says that she only feels pain when the area is touched in some way, whether it's through sex, through a tampon, through a gynecologic exam. And then there's a second condition, also very common, called generalized vulvodynia or dysesthetic vulvodynia. And that's the woman who says the pain is always there, even when the area is not being touched. She's in constant pain.
Mm-hmm. So that's independent of lovemaking. And so that is going to affect somebody's job. It's going to affect the ability to parent, to be in a relationship. It's going to affect their mood because it's very, very difficult for women who suffer with genital pain.
That's right. And with both of these conditions, the effects of having the conditions span far beyond herself and her intimate relationship. They can have an impact on her sense of well-being, on her ability to work, on her ability to wear clothing, etc. So the effects are pretty profound.
And how often do you get the question, is this in my head?
Every day, multiple times a day. And primarily we get asked that question because unfortunately, many women are told that. And the reason for that is because when women will see usually their family doctor, first of all, sometimes they'll be referred to a specialist like an OBGYN. But when a physician does an exam of these women, there's nothing observable to the naked eye. There's no signs of redness. There's no signs of any kind of infection. And so that leads the physician to conclude, well, this must be in your head if there's no obvious signs of something wrong happening. And so along with the message that this must be in your head, sometimes there's rather unhelpful pieces of advice given, like, go home and have a glass of wine, or maybe you don't like your partner, or maybe this is a sign of really something bigger that's going on with you. And I think it's really important to emphasize that all of those messages are absolutely incorrect.
Right. And this is not the kind of thing you can say to your mother or to your friend or to your sister. I have genital pain. It hurts for me to sit down. People may try and compensate for it and behave, in a bizarre way at work, for example, sitting on pads or trying all sorts of different treatment options that are not going to be helpful.
Yeah, I mean, it's a very unique kind of pain because of its location, and we have much more comfort talking about knee pain or back pain than we do about vulvar pain. And some data that we've collected in our lab suggests that, it shows that women will suffer with their pain on average about 5 years before they receive an accurate diagnosis. And so over the course of those 5 years, of course, the condition itself is worsening, and then the effects of the condition on the woman's well-being, her mood, her relationship are also worsening over time. And so we try as much as we can to talk to the public, talk to women, but also talk to physicians about identifying this condition and intervening much, much earlier so women don't have to suffer in silence for 5 years.
Exactly. I think when doctors don't know about certain conditions because they may not see them very frequently, urinary incontinence is another subject matter that GPs may see a lot but don't really know what to do with, and it takes a long time to treat these, and it takes a long time to treat provoked vestibulodynia as well and the other vulvar pain. But when we come back, we're going to talk about what causes this type of pain in the genital area. I'm Maureen McGrath, and you're listening to the CKNW Sunday Night Sex Show. Welcome back. I'm Maureen McGrath. Sex does hurt sometimes, and it's not normal. Love hurts, too. And that can be some of the most challenging pain. But right now we're talking about sexual pain, chronic genital pain, which is independent of lovemaking. The landmark Sex in America survey estimates that sexual pain affects 20% of American women, 15% before menopause, and 33% afterward. And until recently, many doctors, and I'm sure many doctors still dismiss women's genital pain as neurotic, which leaves them really wounded. Dr. Lori Brotto and Dr. Carolin Klein are both here in the studio with me, and we're talking about provoked vestibulodynia. I know that's a big word, and we'll have a spelling test later. But Dr. Brotto, what causes vulvodynia or PVD, provoked vestibulodynia?
So, Maureen, I'm going to focus on the second, provoked vestibulodynia. And the reason for that is because there's been so much more research focused on that. And the Canadian Institutes of Health Research, which is our major federal funding agency funding health research, has really taken to this condition, and over the last couple of years has funded a number of studies trying to answer that question of what causes PVD. And the answer is we really don't know. There is no single cause for any woman. We know that there's a number of risk factors that the majority of women have. So, for example, there seems to be a genetic component to it. So a woman who has a family history of other pain conditions like fibromyalgia, irritable bowel syndrome, temporomandibular jaw pain, so pain grinding your teeth, as well as interstitial cystitis, which is a bladder condition. Those women tend to have a higher risk of developing provoked vestibulodynia, and they also tend to be more likely to also have those other conditions as well. It also seems that women are more likely to have a history of recurrent yeast infections, so that might set up some kind of sensitizing of the local area that then predisposes them to have the pain later on. There's also some research suggesting that women who start to use the oral contraceptive pill from a young age and for many years might also be a little bit vulnerable.
How about women with anxiety disorders?
Yeah, so,
and I'm sure it actually leads to anxiety disorders if they're suffering, so it's a bit of a catch-22.
Of course, and if you could imagine hearing these women's stories, women will essentially talk about the pain as feeling like there's razor blades or knives at the opening of their vagina. And so understandably over time, this has profound effects on her mood, on her anxiety. But there's also research showing that women who have a history of anxiety and depression before pain actually puts them at 11 times the greater risk of developing provoked vestibulodynia later on. So it's not to say that this is a psychological disorder or that this is a result of someone's psychological makeup, but rather it's saying that women who have a history of mood symptoms might be at slightly higher risk for developing this.
And it's often a nerve pain. Is it? It's considered a nerve pain. It could be related to neurotransmitters, which is also related to mood disorders.
That's right, and that's where the bulk of the research is looking at now. And the really one of the best explanations that I've heard and certainly share with my patients, it's like the alarm system in your brain that signals pain is firing when the cat is walking across the floor, as opposed to when there's a real intruder breaking into your house. So the pain center in your brain is signaling pain, pain, pain when there's only touch in the area.
Mm-hmm. And how about the impact of the conditions on patients and partners? Now, men, according to some research, men don't necessarily believe I'm sure they can't understand it, the sexual pain of women. And also some men believe that sex should hurt. It should be painful.
Yeah, so this also has been an area of increasing really, really great research, is looking at the impact of having this on a partner. And certainly in speaking with patients and their partners, I speak with many men who will say, this can't possibly be real. I've had many past partners who've never had this condition before. Is this, is this a sign of us not being compatible? So we do a fair bit of educating to partners, whether the partner's male or female, explaining what the condition is. And there's actually more than that. We know that how the male partner relates and communicates to a woman can actually have an impact on her recovery.
I'm sure. Absolutely. If somebody's understanding, it's a lot better recovering from anything, really. And so this is not in a patient's head. That's one of the key messages. And also patients are not alone with this. Often women feel like I'm the only one. I get that question a lot. Have you ever seen anybody like this before? I think I have seen 40 of you this week, with prolapse, for example, or urinary incontinence or vaginal atrophy. So they're very common conditions, but because they're such taboo subjects, we don't actually talk about it. So Dr. Carolin Klein, we're going to talk to you about the treatments that are available for genital pain, for provoked vestibulodynia.
Yes, and there are actually a number of different treatment approaches. One thing to note is that at this time, we don't know from the research which specific treatment approaches will be beneficial to which women specifically. But in general, we know that a multidisciplinary approach or a number of different types of treatments are usually what's been found to be most effective. So the treatment approaches, there's a number of them, from medical approaches to pelvic floor physiotherapy to psychological approaches. Within the medical approaches, everything from oral medications, so things like the tricyclic antidepressants or even anticonvulsants. These medications are often a first-line treatment by physicians, but actually the research shows that they are not the most effective. They can sometimes help to reduce the pain, but rarely from the research are they shown to actually fully eliminate the pain. Other medications can involve topical medications, so things like estrogen creams can be very effective.
The low-dose localized estrogen cream.
That's correct.
Like Premarin cream or Estrogyn or an E-string.
Estradiol, yes. And physicians will also often recommend that women before intercourse use something like lidocaine or xylocaine cream 10 minutes prior to intercourse to help them through that as well.
And will that also decrease sensation? Because that's effectively an anesthetic, a topical anesthetic.
Yes, it can.
So can that decrease the pleasure of the intimacy as well?
Yes, but so will the pain.
Of course, the pain. You will perhaps avoid sex altogether. So it's kind of you're choosing your...
That's right. And in our program, the Multidisciplinary Vulvodynia program, oftentimes we're looking at medications only after we've looked at other techniques first because of the side effects of the medications or the result that the medications are not always as effective at eliminating the pain.
And how about vaginal probiotics? Do you use that in... you do not use that with provoked vestibulodynia.
No.
Because we do use that with vaginal atrophy, and some women will have, or some pelvic pain, so more internal pain, and definitely have seen some increased lubrication. That's basically what the probiotics will do, balance the vaginal environment.
Yeah, no, we don't have any research support for that, but definitely we are recommending for women to use lubricants if they are going to be engaging in sexual activity to help reduce the chances of any pain through that.
Okay, and how about personal moisturizers? Would those help?
Again, very cautious about what women are applying to the skin because many things can be an irritant. So really giving recommendations to make sure that they are using things that don't have a lot of chemicals in them, but definitely lubricants.
How about the psychological education, the psychoeducational development?
Yes.
work that you do.
Yeah, many psychological, there's a lot of research showing that psychological approaches can be very helpful in reducing pain and helping women to cope with the distress that they have from pain. And that, again, is not to say that the pain is in a woman's head because psychological approaches help, but rather we know that pain has not only sensory components, but also is very much influenced by thoughts and emotions. So if we anticipate something to be very painful, it is in fact experienced as more painful. And psychological approaches can very much help with decatastrophizing, anticipating positive outcomes, reducing stress. Stress also will exacerbate pain. And then,
I was going to say, basic education.
Very much so.
Sexual response cycle for women.
Yes. The other big one I was going to mention is that because with provoked vestibulodynia, so much of what happens is that women then begin to notice that they have a drop in desire as an understandable result of having pain. What happens is it interferes in their sexual relationship, and psychological approaches can very much help them to find ways of continuing to be sexual in ways that don't exacerbate the pain.
Exactly. We're going to head to break, but I'm going to ask you to stay because you have some research studies and how women can access your services in your program. I'm Maureen McGrath. You're listening to the CKNW Sunday Night Sex Show. Welcome back. We're talking about sexual pain with Dr. Lori Brotto and Dr. Carolin Klein, and they have run the Multidisciplinary Vulvodynia program at Vancouver Hospital. So, Dr. Brotto, if somebody thinks they have PVD or provoked vestibulodynia, what can they do?
Well, I think the most important thing is to speak to a family doctor and get an examination done, as well as a very thorough history. And if the woman feels like her family doctor is not listening to her, taking her complaint seriously, then asking for a referral to a specialist, to an OBGYN. On our website, which is mvprogram.org, we have about a half an hour educational video that we recorded that we often send patients to look at this public forum. And in the video, you'll see a number of different providers really talking about what is the condition, what to look for in a diagnosis, how do we manage and how do we treat this. And so I would also recommend that if any of the listeners are experiencing what might be provoked vestibulodynia, to actually look at the website and look at that video.
Okay, that's great. And Dr. Klein, you have some research studies going on?
Yes, and actually I'll let Dr. Brotto speak about them because actually Dr. Brotto has been heading those.
Okay.
So these are through the UBC Sexual Health Lab, and we've got a couple of studies going on specifically on women with provoked genital pain. And one is taking a look at decisions that pregnant women with genital pain might make. And as you can understand, a woman with pain and thinking about her upcoming delivery might have a number of questions and anxiety around how the delivery is going to impact her pain. And there's really been no research on that to therefore guide physicians to counsel women how they might manage their pregnancy and delivery. So we are interviewing women and following throughout their pregnancy and afterwards to see just what impact having provoked genital pain on delivery has. Does this worsen the condition? Does it improve it? A second study we're doing is actually using an 8-session psychological treatment for women with provoked genital pain. And so women can find out much more about both of those studies by looking at our research website, which is obgyn.ubc.ca/sexual health.
Excellent. Well, thank you both so much. It's such important work. It affects so many women, and it affects relationships and quality of life. And I thank you all for the fabulous work that you're doing.
Thank you. Thanks for having us, Maureen.